to introduce you to our speaker, Dr. Greg Davis. Dr. Greg Davis is the Chief Medical Officer of the Illinois Rural Community Care Organization. As a board-certified family physician, he has practiced in rural Illinois for the last 36 years. Additional experiences have included service as the Chief Executive Officer, a member of the Board of Directors of a critical care hospital, and a mediator to resolve conflicts between hospitals and providers. In 2016, he received the Rural Physician of Excellence Award by the Illinois Health Association, State of Illinois Senate Recognition Award, and the Illinois House of Representatives H.R. Bill 1436. Now I will turn it over to Dr. Davis.
Good afternoon. Kind of start by looking at the agenda that I've laid out for the next several minutes. I want to talk a little bit about just medical economics, where we're at right now, a little bit about value-based payment framework, the rise of the ACOs, the alphabet soup that we're involved in with MIPS, MACRA, and APMs, some implied messages that I think are coming from CMS, and then some new opportunities for revenue. To start with, let's talk a little bit about our medical economic situation. This is a graph that probably many people have seen some form of in the past, and the top line is the one of consequence, showing the percentage of GDP that's being consumed on an annual basis, starting back in 1989, where it was about 11%, to 2016, which is now off that graph, but is basically at 20% of GDP is being consumed in our healthcare dollars. The importance of that is that this is an unsustainable event, which means that we will have changes that are sustained regardless of the political climate that we find ourselves in. Now, if we move on to take a little bit about just the value-based payment framework, I think this gives you an idea of where we've been and kind of where we're going. On the left-hand side, there's traditional fee-for-service, then it's the adjusted fee-for-service, then the APMs with fee-for-service, which is, we're kind of in that transition between those last two, and then ultimately going to population-based APMs, which are really a comprehensive care, and in many ways will be, I'm pretty comfortable in saying, ultimately will turn into a full capitated program that most all of our payers will be involved in. So that's kind of the transition that we're moving through, and we're about midway in that process. That's being manifested by the rise in the accountable care organizations. If you can note on the graph in 2011, which is on the left-hand side, there was less than 100 ACOs. By 2016, we're now, and actually in 2017, we're in excess of 900 ACOs. So you can see that this, the accountable care organization concept is really taking hold. In addition to that, if you ask questions about the payers, what's the rise of all types of payers, it's kind of the same kind of line. Back in 2011, there was only 44 payers. Now, these are commercial and governmental payers. But as you can see, that's doubled or tripled by 2015. So we're seeing a lot of interest in commercial carriers in the ACO model. I personally have been involved in discussions with Blue Cross Blue Shield in Illinois. I know Aetna is also involved in these kinds of decisions, and we're seeing this kind of a process being rolled out not only in the governmental payers, but in our commercial payers. So, you know, I guess the implied question that I always think of is, what do I, out of the actions of CMS, what are they telling me, and how's that going to play into my future? Well, I think the first thing that they're telling me that they're incentivizing us to join large groups. And we'll talk a little bit about that in a few minutes, where you can see what the impact of macro will have on the small solo groups or groups even in less than 100 providers. They're certainly attempting to bend the cost curve, which basically the underlying medical economics is showing us that that's going to have to happen. It's unsustainable. I've read projections that by 2040, that under current rate, we will consume 100% of GDP in medical care. Obviously, that's not a sustainable event. We have to have bridges and roads and et cetera. They're certainly incentivizing and measuring quality. That's very obvious in macro. They're incentivizing, incenting, or they're enhancing provider transparency. Starting in next year, the public will be able to go online and get specific composite data regarding their providers and how they've played out in the quality indicators that CMS has set up. They're incentivizing providers to join quality payment programs. It's clear that they're driving toward the advanced payment models. There are not a lot of them available currently, but they're rolling them out, and they're ultimately going to try to push us all into that type of program. And then ultimately, macro will impact all providers. Many of the physicians that I deal with are involved in rural health clinics, and because of the rural health clinic being an entity attached to a critical access hospital, they feel somewhat shielded from this process. But it's clear that that shield is temporary and is actually incomplete. The activities that they're involved with that are outside of what happens in the rural health clinic are still going to be impacted by macro starting in 2019. So the takeaway ideas that I had at this point are that the ACOs are basically here to stay. They're spreading, and the transition from volume to value will continue. It was a bipartisan event that occurred, had very strong backing, and in our travels in the political spheres of Washington, nobody is talking about getting rid of the transition of volume to value, and ACOs really are the only thing on the board currently that is a mechanism that CMS and commercial players will be able to bend that cost curve. So I think they're here to stay. Yeah, just a little bit about macro. When I first started looking at macro, I was a little bit confused by the alphabet soup that I was dealing with. So if we just took a look at macro, which is the Medicare Access and CHIPS Reauthorization Act, it breaks into the quality payment programs, of which there's two types, which I'll speak of later, and that's the Advanced Alternative Payment Model, and MIPS, or the Merit-Based Incentive Payment System. So that just kind of shows you how the diagram breaks down. Ultimately, macro will hit the vast majority of clinicians. Currently, in years 1 and 2, on the left-hand side, you can see that it's basically physicians, chiropractors, some PAs and CRNAs are involved. But by year 3, it's going to be basically all people that are involved in any kind of delivery of services. Audiologists, language pathologists, nurse midwives, et cetera, will all be rolled in by that point in time. So it's a growing event. And certainly next year, and then the next couple of years, most providers will be subject to MIPS. This is not scaled to, meaning the more people on the left-hand side at 20 or so compared to 6 or 7 on the right-hand side. Those are not proportionate. It's meant to simply mean that the majority of providers will be in MIPS. There will be a few qualified providers that are in advanced payment models, and then many more will be in the non-advanced APMs and still be subject to MIPS in that setting. So who is exempt? I talked a little bit about my rural health clinic physicians and providers believe they are. Well, there are actually a few people that are. The newly enrolled providers, your first year in Medicare, will get you an exemption. If you're a low volume provider, meaning less than 100 Medicare patients, and you're billing less than $30,000 per year, that's pretty low. And by 2018, you could be exempt from MIPS by being involved in a qualified alternative payment model. And there's two methods to get into that. One is 25% of your Medicare payments go through an APM, or 20% of your patients are attributed to an advanced APM. This is a projection that I ran based upon what CMS is telling us, what we can expect to happen in purchasing power over time. You can see that in the middle is the 0 point, and I have the 2019 to 2022. Theoretically, you could start getting incentives at 4% in 2019 of your Medicare payment if you met all quality indicators, ramping up to 9% by 2022. But it's a mirror image because this is a budget neutral process, so that for every potential gain, there's also a potential loss. Unfortunately, this graph, as it was played out, did not show the effect of inflation. This graph does. If you take the historic rate of inflation at 3% in the United States, you can see from this graph that the downside risk is substantially higher than the upside potential. And that's because the Medicare fee structure, baseline fee schedule, is flat without any incentives or without any inflation adjustment. This strongly suggests that the vast majority of providers will actually see a contraction of their purchasing capability over the next 10 years. I talked a little bit earlier about the impact of size, practice size by MIPS. When macro was first being brought out and being considered and was out for a public comment, the CMS included a graph in their comment document that showed their projections of what was going to happen to practitioners depending upon practice size, the probability of that practitioner having a negative adjustment. As you can see, that if you're in solo practice, the projection was, and I think probably still is, that the probability that in 2019 and beyond you having a negative adjustment is 87%. And you have to get up to over 100 people in a practice to have a significant probability of actually having gain through the MIPS program. So this is not good news for small groups. It will incentivize strongly the conversion into larger group practices in order to obtain some of the incentives that are being offered through this program. So we can see we are anticipating continued contraction in practice sizes or practice numbers. Now, an advanced APM, which I talked about, is an advanced alternative payment model. There's a few things that are characteristic of them. And in the 2019 through 2024 time frame, if you were to make the transition into an advanced payment model, you will start out with a 5% bonus on your Medicare fee structure. That bonus is a limited time frame, but it does impact the decision of when you make that transition into an advanced payment model. If you get there during this window of 2019 through 2024, you can participate in this 5% giveaway or bonus. After that, it's projected that the bonus is gone. So you're weighing the risk of downside, or the downside risk with the given of a guaranteed bonus as you make that transition during this time window. You can see that there are certain things that have to be involved. The provider has to be qualified, and we'll talk a little bit about what a qualified provider is in another slide. The EHRs have to be certified, so there's an ingoing cost that has to be considered in this decision, and the quality program reporting programs in the advanced APMs are very similar to MIPS. There are some advantages also being in a patient-centered medical home. And there has to be more than what's considered a nominal bidirectional risk. The exact definition of nominal has yet to be completely laid out. But I think you can assume that if MIPS is looking at the 4 to 9% up bidirectional risk, you're going to probably need to have somewhere in that range in order to be considered as an advanced APM. The categories of APMs that are available are the pay for performance, the shared savings, the episodic payments, and the global budgeting. And we can talk a little bit on the next slide about the more specifics. You can see that currently available are the Medicare Shared Savings Track 1 Plus, 2, and 3, Next Gen, the End-Stage Renal Disease Comprehensive Care, Comprehensive Primary Care Plus, and Oncology Care. There are developments of those noted on the right-hand side of the slide, such as the Diabetic Prevention Program. So we have a fairly limited menu of advanced alternative payment models that are currently available to us. Track 1 Plus being a very major opportunity for rural health organizations. But there's more on the board, and we can certainly anticipate that there's going to be more coming out as rapidly as they can define them. So I talked a little earlier about what it takes to be a qualified provider, and in order to achieve an advanced payment model, you have to be defined as a qualifying provider. What I've shown on this is the qualifying provider percentage of payment. These are the thresholds of either initially in 2019, the percentage of payment that has to be coming through that advanced payment model at about 25%. But more importantly, what you can see is a drive of CMS to push us into advanced payment models. Because as we move along, not only do you have to have the 25% or so of Medicare, you have to have a rising percentage of your payments coming through the advanced payment models in order to be considered qualifying. And you get to start using the combination of commercial and Medicare when determining that payment threshold. This is a clear indication that Medicare is encouraging the pursuit of providers moving into advanced payment models for both Medicare and commercial players. Same type of thing occurs if you take a look at patient counts. The numbers, it's 20% in 2019 of your Medicare patients have to go through the advanced payment model to be considered qualified. But the same incentive is still present. Medicare is showing us that they're starting to put in the combination of commercial and Medicare patients in a rising threshold to be considered an advanced payment model. So this is another push on the distribution or deployment of advanced payment models across all payer categories. So the impact on providers. Well, yeah, I talked a little about that you have to make a decision at some point. You have to come up with a strategy, either to maximize your MIPS reimbursement or join an advanced APM and become a qualified provider. The things that needed to be considered are the increasing qualified provider threshold. When are you going to get in? Because there is a bonus, and it's also harder to make it as that threshold rises. Considering and remembering the adoption of the value-based payment in the commercial model, the need for health information technology and its associated costs of the certified technology. Certainly a need for practice redesign in order to meet the quality indicators, and then the timing of the transition from MIPS to an advanced payment plan, balancing the downside risk of the advanced payment model against the 5% bonus window. There's also a focus on coordination among providers. When looking at ACOs, the ACOs that can control as much of the spend, including the downstream spend in the of their patient base, will do better. So the higher the level of coordination, the higher the probability of that advanced payment model will ultimately be successful and profitable. There's also technology and processes which will drive provider consolidation. We talked about mergers into larger groups. There's also now discussion regarding the usage of and formation of virtual groups to allow us that are in rural areas to potentially get into a virtual group and ramp up our numbers to over that magic number of 100 providers in a group to increase the probability of achieving savings through these models. I'm going to move on to the next slide. I've talked about that. In 2017, we've got MIPS, or CMS gave us the Pick Your Pace. This was an opportunity for clinicians in the first to use the data of the first quarter of 2018 to get a neutral to a possibly a small positive adjustment. The important thing here is that if clinicians will simply report any indicator, they can avoid the 4% adjustment. If you simply ignore it, they will take a 4% adjustment from your CMS reimbursement. The reporting options in 17. As I said, if you don't do anything, you're going to lose 4% of your Medicare revenue. If you do something, you can remain at 0, like you were last year. If you can submit partial submission for a 90-day period, you're going to be subject to a small possibility of getting a small bonus. And then if you used a full 4-quarter, there's going to be the opportunity for a more modest bonus at the end of the year. The performance cycle, just to give you an idea how these things play out, if you look on the left-hand side for calendar year 2017, it's the measurement year where you can elect either a 90 or a 1 or a 4-quarter period to be measured against. In 2018, by March 31st, you have to have reported your 2017 experience. In the third quarter 2018, CMS will give you some feedback about how you did, and in the first part of 2019, you will start having adjustments made on your 2017 performance, and that will continually roll forward over time. So it kind of gives you that time frame of how these performance submission and ultimate adjustment times will be laid out. takeaway ideas to this point. CMS is allowing providers to ease into the pay for value. That's the pick your pays. You need to report something in 2017. Don't forget that the Medicare fee schedule is frozen for several years and will not be keeping up with historic inflation rates. CMS is encouraging the transition to alternative pay models, including commercial payers, and they're doing it by a multitude of ways that we've talked about, including that increasing threshold, including your commercial payer revenue. And to be successful, providers really must make that transition to a risk-bearing contract. Data options. I said you had to report something. Well, there's 3 buckets for the 2017 database that you'll be able to report on. One is the quality measures, which is in essence has been the PQRS in the past, so not much changed. There's advanced care information, which will replace the meaningful use component. And then there's clinical improvement activities, and we can talk a little bit about that, but it's a more ill-defined group. But you'll need to at least pick one of these methods in order to prevent that 4% reduction in your Medicare revenue. There are some good news. As we move into these processes, there's opportunities for new revenue sources. We talked about there's opportunities in MIPS and alternative payment models if you perform well to achieve bonuses. Commercial ACOs are being built on the same type of process. Medicaid across the United States is also actively moving into an ACO type model. Medicare well visits, there's a nice opportunity for a revenue stream there for providing wellness services to your Medicare population. Gap closures. These are the things that all of us as clinicians would have liked to done for all of our patients over the years, but because of time constraints, it was difficult to remember to get them done. Such things as what percentage of your women that are eligible for mammogram have had a mammogram in the last year. How many patients have been screened for diabetes, hyperlipidemia? What's your average systolic blood pressure? These are all things that I know as I look through my data, initially I thought, gee, I think I'm doing real well in colorectal screening. But unfortunately found out I was about 50% of my patients had been screened. We tend to overguess how well we're doing in these screening processes because the patients that we're not considering are the ones that never walk in our office on a routine basis. There's potential revenue in transition of care management, chronic care management, and certainly better utilization of services. We've seen in our ACO that as a most glaring example, we had one patient that presented to the emergency room in 2015 165 times. That patient really rang the bell for the most abusive usage of the emergency rooms. So there's innovation available and opportunities for innovation in improving utilization, getting the patient to the right place at the right time in order to improve the outcome and reduce the cost of services that are being provided to those patients. And that actually turns out to be a significant source of potential revenue, along with care gap closure. Those are the two areas where there's really the most opportunity for additional revenue. Talk a little bit about care coordination, because the central aspect of an ACO really all centers around care coordination. On a local level, we utilize a care coordinator that can coordinate and track Medicare well visits, transition care management, care gap closure, measures, utilization reduction projects, and chronic disease management. I also took a small opportunity to, when I was speaking to the CFOs in our ACO, the first thing they ask about is, well, you're talking about reducing the number of people coming into the emergency room, increasing your outpatient visits. It sounds like there's going to be less patients in the hospital. It sounds like revenue is going to get reduced because utilization is going to get reduced. And that's probably true in those particular revenue streams. But I thought I'd do a little modeling using my practice and see if we looked at it and ramped it up across the ACO, what kind of a return on revenue could we get? For every dollar that's lost in utilization, is there money that comes back from all these other activities that can offset that loss in volume? So I think it's important that anytime we talk about a modeling assumption that patients or people really need to know what's the underlying assumptions of that model to see if it's reasonable or not. So I'm going to run through those assumptions, telling you that this is based off my practice data. I'm a solo practitioner. I have about 2,000 patients. I see roughly 25 patients a day. So one of the assumptions is that these practices look like my practice. If we assume an adoption rate across a 3-year ramp up, as I show there at 25% adoption in the first year, ramping up to 50% by the 3rd year, so still 50% of that will not be involved or in these evaluations. And a rollout looking at 48 providers in the first year, 100, and then 148 providers in the 3rd year. Assuming that 66% of patients in Medicare qualify for chronic disease management. And I think looking at my population base, that's a reasonable assumption. I also assumed 78 annual admissions with 66% qualifying for transition to care. That's based upon my practice. I have about 70 to 100 admissions per year, and about 66 or 2/3 of those will qualify for transition care. And then 20% of the patients have gaps that can be closed in their care, those mammograms, colonoscopies, et cetera, and that would result in a revenue of about $800 per month per patient. Now that's, I have to say, that's probably the black box in this analysis. That $800 a month is based upon some proprietary information that I had available to me. And as I spoke to several CFOs, they tend to think that that's a reasonable estimate. But it is the most unknown of all the factors in my modeling assumptions. To give you some of the outcomes, if you looked at the various revenue streams down the left-hand side, you can see the totals using the assumptions that I laid out in millions of dollars at the bottom. If you go to the next slide and talk about the impact of volume to value in the transition, it turns out that for about every $1 lost due to volume reductions, there's between a $3 and $6 gain from the other revenue streams. So there is a positive ROI that's available in a fully deployed care management program. And I have to stress that. If any part of that care management program is not rolled out, you cannot achieve a positive ROI. Now, the other things that you will get on a side is, we believe, a very good opportunity for gain in market share. And the rationale behind that is that the best form of marketing is word of mouth in medical care. This is one of best ways I've ever heard of at creating positive word of mouth. Patients that would be contacted by a care coordinator and develop a relationship with a care coordinator are going to be quick to talk to their neighbors about that type of relationship. And odds are your competitor is not matching you up on that type of service. So it's a really good opportunity to gain some market share. Well, I think without a doubt, one of the things that we've seen across all the ACOs is one of the things first thing that happens is they improve the quality indicators of the care that they provide to the population. So I think your care is going to improve without a doubt. And then on the bottom, you're positively positioned for commercial contracts. You've seen earlier on one of my slides the ramp-up rate of ACOs and the rapid adoption of the ACO model by commercial carriers. So the takeaway ideas at this point are to maintain and grow your revenue, you need to implement